Next section, title, Obstructive Restriction. Procedures that are based on obstruction and their mechanism of action and the mechanism of failure. Restriction, obstruction. The goal of restrictive surgical procedures is to decrease caloric intake, and the decreased caloric intake leads to a weight loss. Because of the massive weight that needs to be lost, the restriction and obstruction needs to be a very high grade. The weight loss then is induced because of a high grade narrowing, the equivalent of the pathologic stricture, a tight circumferential narrowing, usually of the stomach or stomach pouch. This obstruction, this blockage, this partial outlet obstruction leads to inhibiting the intake of normal healthy foods. So foods such as broccoli, cauliflower, carrots, sandwiches, hard fruit such as apple, and foods like this that can be swallowed and have relatively solid or bulky portions, like the flowerets of a broccoli, induce feelings of pain, distension, and oftentimes vomiting. If this is repeated, there can be dilation of the pouch, and if the band remains in place or there's still a tight stricture, the dilation can proceed and get worse. But what often happens is the patient recognizes that all of these lists of healthy foods, a bite of steak, solid, bulky foods like this lead to tremendous pain, discomfort, and vomiting and retching. A tremendously uncomfortable, unpleasant experience. So what this does is basically as if the patient is receiving a shock from an electric cattle prod. Every time they try to eat these types of foods, these healthy foods, they receive adverse conditioning. They are shocked. They are hurt. They are made to vomit and spit up. They are placed in great pain. So this induces pathologic eating. They learn that if they touch the stove, it's hot. If they put their finger in a light socket, it hurts. If they put their hand in a hole, a snake will bite them. So they stop doing that. The operation teaches them to eat badly. They learn that certain foods will go down because they've tried everything. And what they learn is something very simple. And that is foods like Coca-Cola, sodas, ice cream, candy, chocolates, potato chips, junk foods, snack foods, things like that go down well. So they begin to eat, and because they have a tremendous desire to eat, because the operation itself has had only a small impact on their desire to eat, and especially after they've starved for a period of weeks or months, they have a tremendous increase in the desire to eat. And with this, they begin snacking and nibbling and drinking soft calories, so that in the morning with a Coca-Cola, several thousand calories can be taken in by a determined individual. And they are determined because they're hungry. And when they try and eat healthy foods that can give them satiety, they often struggle with nausea and vomiting, so they learn they don't eat those healthier foods. Ultimately, this ends up all in the same place. No matter what type of restrictive procedure, all of them ultimately result in weight regain. Next section, heading, selecting an operative procedure based on safety and effectiveness. We're now going to discuss the mini-gastric bypass based on personal experience, animal models, expert judgment, published data, and controlled prospective randomized trials. Each and every one of these types of lines of evidence show one and only one outcome. That the MGB is more effective than the sleeve, the Roux-en-Y, the lap band, or the other operations. The MGB is safer than the sleeve and the Roux-en-Y, but only in well-trained hands. And this is the next part of our discussion. Again, we need to emphasize why the band, the sleeve, and the Roux-en-Y fail. Essentially, all obstructive restrictive procedures block the intake of relatively healthy foods and induce forcefully the intake of sweets, liquid calories, and junk foods. Thus, we can see that for the past 20 to 40 years, there's a litany of failure of weight loss surgery. The treatment failure rate is extremely high, above 50% in almost every study that's beyond 5 to 10 years. Pathologic dietary choices induced by obstructive bariatric surgery includes the intake of sweets, ice cream, candy bars, Coca-Cola, and other sweet drinks. The Roux-en-Y and the sleeve and the band create sweet or junk food eaters. All obstructive procedures, including the Roux-en-Y, make sweet eaters. This mechanical block of normal healthy foods is associated with early weight loss, a honeymoon period that usually is between 2 to 3 years. Then there is failure with weight regain. Why is there growing chorus in favor of banning the Roux-en-Y? Because the Roux-en-Y fails over time. The band, the sleeve, and the Roux-en-Y block normal healthy foods. This initially causes weight loss, but then there is increased hunger, decreased satiety. Healthy foods are blocked, and so the lack of satiety and hunger drive the patient to eat, and what follows is a desire to eat and inability to eat healthy, and so other junk, unfortunate choices in foods are made. Next section. But what about the MGB? What is the mechanism of action of the MGB? And the MGB has two mechanisms of action: restriction without obstruction and an impact on the intake of fatty foods, including fatty food intolerance and a mild malabsorption. So the mini-gastric bypass is a surgical treatment of obesity and diabetes, one based on non-obstructive restriction. And this is different but similar to what we've been talking about, but it's so different it's important to emphasize. All of the other operations we discussed are based upon obstructive restriction. That is, it's a roadblock. The MGB does decrease the intake of food. In our series, approximately 75% less food is taken in after operation compared to preoperatively on recall testing. But this decrease is not based on obstruction. There is no tight, narrow obstructive pouch. There is no tight, narrow obstructive gastrojejunostomy. And this is a common misconception among surgeons performing the surgery. It's important to emphasize that creating an obstruction here, in fact, inhibits the effectiveness of the operation. Number two is that not only is the food dumped quickly into the small intestine, but in addition to that, fatty food dumped quickly into the small intestine has a similar aversive conditioning to the patient, so that the post-gastrectomy syndrome, the patients are dumping food rapidly into the small intestine, and following this, the patient has a response, aversion of dumping, discomfort, and nausea, so that sweets, sugars, liquid calories induce a very uncomfortable feeling and sometimes actual dumping with hyper and hypoglycemia, or the type 1 dumping with a rush of fluid into the lumen of the small bowel, followed by abdominal distension and pain, nausea, and vomiting. Fatty foods, bulky foods, all of these can cause problems, but fresh fruits and vegetables and small amounts of high fiber foods work quite well. Number three is there is malabsorption of fat, but it's minimal. The majority of the change in the diet of a patient with mini-gastric bypass is fatty food intolerance, so that they eat a much lower fat diet. And so this needs to be emphasized, because oftentimes there's a great amount of confusion among surgeons who somehow think that the short bypass of the MGB is somehow similar to the massive bypasses that occur with the jejunal-ileal bypass, the biliopancreatic diversion, and other types of operation, which is not the case. Finally, the research shows that there is a significant decrease in hunger. When we use a visual analog scale, the preoperative compared to postoperative hunger on a 0 to 10 scale goes from a little above 7 preoperatively, very hungry, to a little above 3 postoperative, which is not very hungry, and this persists for years. The other thing is that the kinds of foods that will be acceptable is almost the exact opposite of what works for the Roux-en-Y, the sleeve, and the band patients. In fact, the food surveys that we've done show that there's an enforcement of the Mediterranean type diet. Preoperative and postoperative hunger levels measured in 2,700 patients of Dr. Rutledge showed that the preoperative hunger level, when measured between 0 and 10, was 7.4 on average preoperatively, and postoperatively up to 5 years out declined to an average of 3.7. So there's a significant impact on hunger in patients who have the mini-gastric bypass. We'll end this part here at slide number 37.